Hello, everyone, and welcome. We're just going to wait for about a minute for other people to join. Okay, so everybody, welcome to our AIHI webinar series for 2021. Today we'll be hearing from Associate Professor Fiona Shan, who will be speaking on suicide prevention and integrated approach to meeting community needs. So just to start off, I'd like to do an acknowledgement of country. So acknowledge the traditional custodians of the land on which we are gathered and pay my respects to their elders, both past and present. And I'd like to extend that respect to all Aboriginal and Torres Strait Islander people with us today. So firstly, just a bit about our speaker. So Associate Professor Fiona Shan is the head of suicide prevention research at the Black Dog Institute at the University of New South Wales. And she's the research director of Lifespan Suicide Prevention, which is a multi-level model of suicide prevention that has been trialled in New South Wales. So she leads a program of suicide prevention research that encompasses clinical, health services, community, universal prevention, and policy. And I've known Fiona for several years now. I've been working with her on the implementation evaluation of the New South Wales and ACT sites of Lifespan. So it's a great pleasure to welcome her today. So this webinar is going to examine integrated suicide prevention strategies that include local communities and discuss a unified approach to policy and prevention programs to support regional suicide prevention planning and activities. It'll touch on a recent large-scale trial of a multi-level model of suicide prevention in Australia and new developments in suicide prevention and the evidence base for it. Just some housekeeping before we start. You can add questions to the Q&A function as we go along. So not the chat function, the Q&A function, which is next to it. And we'll have a discussion at the end and opportunity to I'll be reading out those questions. Now, reminder that the presentation is being recorded, but it won't show the names or faces of the audience. And just a plug for the next seminar, everyone registered with this event will receive a notification of when bookings open for the next event, and that will be on the 23rd of June. And our speaker will be Professor Kathy Eager, who will be sharing aged care research with particular focus on workforce issues. That should be a really good one. Professor Eager is Director of the Australian Health Services Research Institute at the University of Wollongong. Okay, so without any further ado, I'm going to hand over to Fiona to give her presentation. Thank you.
Thanks, Janet. It's a great pleasure to be here. I'm very honoured to have been invited. So let me just start by sharing my screen. Okay, there we are. So, as Janet said, I'll be talking all things suicide prevention today and looking at policies, the frameworks for suicide prevention that we currently have and use, as well as practices and evidence for all of those. And importantly, looking at how do we integrate across all of those things, because with a problem that's as complex as suicide, we really need that integration. And that's the thing I think that has been missing over recent decades in suicide prevention. So one of the things that has been quite useful in the work that we've been doing was a systematic review of all evidence for suicide prevention activities that was done by Gil Salzman and a bunch of other academics And really what they concluded is that no single strategy on its own is likely to have an impact on suicide rates. We really do need those multiple approaches that are integrated. So, you know, there's a clear rationale, I suppose, for these multi-level models that we're trialling. And I will talk about those, as Janet said, as we go through the presentation. I would also like to add my acknowledgement to the traditional custodians of the land in which we're meeting. For me, that's Gadigal land of the people of the Eora Nation, and to acknowledge and respect their continuing culture, connection to land and sea, and the contribution they make to the life of this city and the region. I'd also like to pay my respects to elders past and present and commit to walking alongside Aboriginal and Torres Strait Islander people to support their social and emotional wellbeing. Given the topic, I would also like to acknowledge those contributing to suicide prevention efforts who are survivors of a suicide attempt, have experienced suicidal behaviour or have been bereaved or impacted by suicide, and to acknowledge the importance of their contribution to the work. So just a bit of background on suicide in Australia. And globally, we sit around the middle of the pack in terms of the rates per 100,000 in suicide deaths. That position is a little tenuous, I suppose, given that not all countries have good data on suicide for a whole range of reasons. But at the moment, what we're seeing is that in the past decade, we've had an increase in the rate per 100,000. So from around about 10 per 100,000 back in 2008, 2009, up to about 13 per 100,000 at the moment. So some of you who follow suicide prevention in the media might know that it is the leading cause of death for young people. That is in part because young people are less likely to die by other means. And actually, when we look at the rates for 100,000, the highest rate tends to be in that 80 and over age group. And the largest group is actually middle-aged men. So around 3/4 of suicide deaths amongst men. If you look at suicide attempts and self-harming behaviour, that ratio flips. So we tend to see it's around 2/3 to 3/4 women to men. We have noted greatly increased attention, and as I was commenting before we started this presentation, fortunately supported by some additional funding in the past 5 or 6 years, with a focus on suicide prevention integrated at a regional level. So it's really pleasing to see that increased focus and the additional resourcing and the changes in policy that we're seeing as well. So I'll talk through some of those as we go through, because in the case of integrated suicide prevention, that policy background is really quite important. So we'll go through the background policy context, and particularly the frameworks that are specific to suicide prevention. I want to touch on the emergence of lived experience as a bit of a social justice movement in suicide. I know that there is a trend towards, you know, inclusion of lived experience, engagement with lived experience across a whole range of areas. I do think it is particularly strong in suicide prevention, so I'll speak to that. I will take you through the lifespan suicide prevention framework, the project that Janet mentioned that we've been working on, and Janet and Yvonne Zurynski and others at the Australian Institute of Health Innovation have been doing the implementation evaluation for that. I want to come to the social determinants of suicide, and in doing so to look at what that means for broader policy. So often we think about suicide prevention being positioned in the health sphere, but actually when we look at the evidence, it's really critical to look more broadly at other policies that impact on suicide outcomes, and then to start to shape up a bit of an approach to integrating suicide across all those, suicide prevention across all of those different levels. So this is a bit of potted history of suicide prevention over the last 12 to 13 years, and I'll step through each of these phases, I suppose. So in 2008, we had the Living is for Everyone framework. So that was the National Suicide Prevention Framework. And it was a good framework. What it lacked was any real resourcing or any way for organisations, health organisations, community networks to actually implement anything. So you can see down the bottom, I've kind of got the increasing rates of suicide per 100,000 from 2008 through to 2019. And look, there will be lots of reasons for that. It isn't just that the LIFE framework probably wasn't implemented well, but given it was our national suicide prevention framework, it's clear it probably wasn't doing what it was supposed to do. So if we move through to 2012, I've got this in here because zero suicides in healthcare is now at the stage where it's being rolled out fairly widely in a range of jurisdictions in Australia, including New South Wales. New South Wales has committed a lot of resourcing to this particular framework, which I will talk about. 2015 was when we started developing up the lifespan framework. To end of 2016, we were fortunate to get a very generous grant from the Paul Ramsay Foundation to actually establish the lifespan framework as a research trial, so to do an implementation/research trial of this framework, and I'll come back to that as well. Following hot on the heels of that, the federal government got wind of this work and decided that they wanted to set up a pilot using a lifespan-style approach to suicide prevention in 12 primary health networks across Australia. So that meant a fairly large scale up of the trial work we were doing. So we had the high fidelity trial in the 4 New South Wales sites. We then had the 12 pilot sites at the national level funded by the federal government. And then ACT Health actually came on board as a site as well. Victorian government funded another 6 sites in their state. So there was kind of this explosion of place-based trials, multi-level suicide prevention frameworks around 2017. So it was a particularly critical turning point in suicide prevention in Australia. In that year, we also had the 5th National Mental Health and Suicide Prevention Plan, and I'll give you a bit of an idea of what that looks like. We also saw the Zero Suicides framework starting to be introduced in Australia, and Queensland actually was the first jurisdiction, I believe, to take that on. Following on from all of this, so New South Wales Health, the Ministry of Health, were very engaged in our lifespan planning and rollout and research. And they developed their own suicide prevention framework, which pleasingly incorporated a number of the lessons that we were learning through the lifespan work. In the same year, the National Suicide Prevention Task Force was established. So the task force is headed up by Christine Morgan, who was the head of the National Mental Health Commission, reporting directly to the Prime Minister. And its brief was really to pull together all we know about suicide prevention. They commissioned probably 25 or 30 studies, including rapid reviews, and they've recently pulled all of that together. And their report, called The Final Advice, was delivered to the Prime Minister earlier this year. One of the things we've also been advocating for, not just us, but many people, is for better access to high-quality suicide data. So we do have coronial data, which is accessible through the National Coronial Information System, but it has a time lag of about 18 months to 2 years because it's coronial inquiries and all the rest before a final determination is made. But what we now know is that state-based registries can set up more or less real-time access to suicide deaths data, which is pretty close to what we find from the coronial data. So increasingly, each jurisdiction is setting up its own suicide registry, so we're getting much better access to real-time data. So you can see there's been huge shifts from about 2016 onwards. There have been massive changes in the suicide prevention landscape in Australia. What did it look like before that? So as I said, we had our national framework. We had individual organisations doing their best to to work in the suicide prevention space. So Lifeline would be a good example of that. And we also had a number of community networks which were established, which were largely community driven and people wanting to make a difference, but really not sure what actions needed to be taken, unclear what the evidence was for what works, and sometimes going for the things that they could do rather than the things that were likely to be effective, because a lot of the work lacked that evidence base. So there was really this disconnect between all these different levels. So the 5th National Mental Health and Suicide Prevention Plan in 2017. So both this and the New South Wales framework are based on the World Health Organization guidelines for suicide prevention. I'm not going to labour on this, but what you'll see as we go through this is that there is a consistency between the national plan, the New South Wales plan, the WHO guidelines, and the lifespan framework. So, for example, there's a focus on surveillance, so having good quality data, a focus on restricting access to means, safe media reporting, having better treatment services available, high quality interventions, good crisis intervention, postvention, and that regional oversight and coordination. And again, you'll see that popping up in the New South Wales framework. So their framework is based around building individual and community resilience and wellbeing. So making sure that people have got access to community-based mental health services, a homelessness strategy, bullying and stigma strategies, and mental health literacy. And that access to community-based mental health services is important. Again, we know from the population level research that with increased access to high quality mental health services, we do see a reduction in suicide rates. What we also know though is that simply targeting mental health is not enough. So it is important to address underlying risk factors for individuals. So that might be a mental illness, it might be substance use, it could be a range of other issues like homelessness, loss of income, the like. But we also need to make sure that our individual level interventions, our treatment plans, our care plans with people immediately address suicidal thoughts and suicidal behaviours as well. So that's at the kind of the clinical intervention level. So strengthening the community response to suicide and suicidal behaviour, so making sure that we have a skilled up workforce with sufficient capacity. There is this emergence of what's known as non-clinical options for people who are experiencing suicidal distress. So they're known as safe spaces, safe havens, safe cafes. And I mentioned that I would touch on the emerging social justice movement, I suppose, with the inclusion of lived experience. And actually, what we saw with the safe havens and safe spaces is that their emergence was really based on strong advocacy from people with a lived experience of suicide. And the idea of this is so that people have a safe place to go, which is not necessarily a clinical service. If they are feeling unsafe, if they're experiencing suicidal thoughts and they're not sure how to keep themselves safe, a lot of these services are supported by a trained peer workforce. They do obviously have access to clinical support if they need it, but they are largely driven by people with their own lived experience who act in a peer support role. And it's emerged in part because of several studies now showing that the emergency department is often not a comfortable or safe place for people who are experiencing suicidal distress. So emergency departments are very well set up to deal with physical injuries, to deal with ill physical health, but they are busy, loud, fast-paced. The staff don't have the time to spend with individual patients that is needed, and they don't necessarily have the skills or the orientation to address psychological distress in the way that they would to address physical problems. So, the EDs have been going through their own reform processes, but they are constrained to working within a system which is quite risk-averse, procedural in nature, and doesn't address those very particular needs of people who are experiencing suicidal distress. So what's happened in New South Wales is that the government has funded the establishment of at least one safe space in every local health district, and we are seeing them pop up in other jurisdictions in Australia as well. And we have applied to do some research to evaluate the effectiveness of those safe spaces. So there is an early evidence base that they are a good option, but we want to strengthen the evidence base around those and make sure that they are doing what they set out to do. So we haven't heard back from the funding agency, but we have our fingers crossed that we'll get the funding to actually do that evaluation. So in the budget, if anyone was paying attention to what was happening in suicide prevention and mental health, you would have noticed that the government is funding even more of a rollout of dedicated aftercare services for people who've made a suicide attempt. Part of the reasoning for that is that we know that the biggest risk factor for death by suicide is having made a previous attempt. So making sure that people receive high quality care following a suicide attempt has a really quite a strong evidence base. So it's good to see the government following the evidence in this case. The funding also includes training up to the community to make sure that people know how to respond if someone is experiencing suicidal distress. We know that when people are feeling suicidal, often their first point of contact is not a health professional, but actually a family member or a close friend, or indeed sometimes a colleague. And so based on the fact that we also know that first response to someone disclosing suicidal thoughts is absolutely critical in terms of their engagement in future help seeking, it is important to make sure that people in the community know how to respond if they are aware of someone's suicidal distress. Again, funding for those establishing regional alliances to coordinate suicide prevention across a region, with funding for coordinator positions there. And importantly, the New South Wales government has also commissioned a fairly substantial program of research and evaluation around this strategy, again, which is really encouraging to see. So I feel like I'm on home turf here. So the lifespan framework, as I said, was the framework that we developed across 2015, 2016. But now you're probably wondering what actually is the lifespan framework. So I'll take you through and describe it in a bit more detail. So lifespan was developed by actually examining the evidence around what works in suicide prevention. And what we came up with were 9 strategies with at least a reasonable evidence base around their effectiveness, which are all implemented within a region in the trial within a 2-year time frame, so more or less simultaneously. A primary outcome in terms of the research trial is looking at a change in self-harm and suicide attempts from the 5 years prior to the baseline to 2 years post-baseline. So we're using coronial data, we're using emergency department data, admitted patient data, and ambulance data to actually evaluate the effectiveness of the framework. It requires a multi-sectoral approach. So you'll see as we go through, when I start talking a bit more about the implementation of this, each region established its own alliance or own collaborative to work together across sectors and across organisations to make sure that the implementation happened in the best way possible. So we came up with a number of guiding principles. It needed to be data-driven, needed to have a strong focus on workforce development, really needed to ensure that we were engaging effectively with people with a lived experience of suicide. Each of the regions has worked to include Aboriginal and Torres Strait Islander communities in their work and to engage more broadly with the community and to make sure that there was that strong sense of community ownership and that they were able to adapt within each strategy to suit the needs of their community. So I'm not sure whether you can read that, but the interventions that the 9 evidence-based strategies go from kind of that pointy end, the crisis end, so improving emergency care and follow-up care for people experiencing suicidal crisis, making sure that we're using an evidence-based approach for treatment, through to those more universal prevention strategies like reducing access to the means of suicide. And to some of you who may not be so familiar with suicide prevention, it does sound surprising that something like means restriction is included, because one would think that people would substitute a means if their original means wasn't available to them. Actually, we find that doesn't happen so much. So means restriction has a pretty good evidence base in terms of reducing rates of suicide and indeed the risk for the individual. And it's based on the idea that a suicidal crisis tends to be more often than not quite transient. So if we're able to protect people and keep them safe during that crisis, we can then support them to recovery following that crisis if we manage to restrict access to means. So in Australia, we have a number of examples. Many decades ago, we restricted use of barbiturates, which were used a lot in overdose and suicide deaths. The gun restriction laws introduced by John Howard back after the Port Arthur massacre were effective in reducing suicide. The restrictions on pollution and people being able to, use carbon monoxide as a way of dying by suicide. Again, we see these kind of high-level strategies being quite effective in reducing rates. We also do things like train the media in safe and purposeful media reporting, and the reason for that is that contagion is a real thing. So good evidence coming out of some European studies that if we talk in the media about high-profile suicides, if we glorify suicide, if we talk about in great detail about the means of suicide use, that we actually do see an increase in rates of suicide. So as an example, when Robin Williams died by suicide, we saw a subsequent increase in suicide rates, and particularly amongst men who were slightly younger than him. So, and clearly someone's death by suicide is not going to affect everyone, but if someone is already feeling quite vulnerable, it can be the thing that makes a difference for them. So we train up media in how to talk safely about suicide, and indeed to focus more on stories of recovery and interviews with people with a lived experience who can share their stories of recovery. And again, we see that having an impact on suicide rates. So I'm not going to take you through the whole wheel. There are 9 strategies that could take up the whole presentation, but just to give you a sense of the kind of work that we were trying to do in the lifespan framework with the 4 regions who were involved. So where did this idea come from? Just to give you a bit of background, I suppose, to this idea of multi-level or multi-strategy models. Actually started back in the early 2000s in Europe. What was the Nuremberg Alliance Against Depression became the European Alliance Against Depression. And the Nuremberg study found that there was a reduction in overall suicide behaviour of around 24% across the 2 years and compared to a control region. They had similar results in a trial in Hungary. I think part of the reason they had such success was because they were starting from quite a high base rate of suicidal behaviour. And so doing anything that was even marginally effective, I think, would have made a difference. Having said that, though, you know, we still think this is the way to go. But what we're finding is that the European Alliance model is having more mixed results as we go through the years and trials in different locations. Part of that is the approach to implementation is quite different. So in Australia, we've used quite a fairly resource-intensive approach to supporting implementation. In the European Alliance Against Depression, they really just provide some printed resources, some guidance and a launch event, and then regions are left to their own devices to sort out how they actually run this model. So they have 4 levels. So they look to try and improve primary care and mental health care. They focus on depression rather than suicide. And again, our view is that the focus needs to be broader than that, because depression is but one risk factor for suicide, and there are many, many that won't be addressed by simply focusing on depression. They have that community capacity building approach by training up community facilitators and stakeholders, a focus on patients, high-risk groups and relatives, and they are actually doing more in the means restriction space in more recent years as well. So really that's where some of the lifespan work came from, was this recognition that a multi-level model could actually be effective in reducing rates at a regional level. So I've already mentioned what the primary outcome is for lifespan, and that we're linking 3 data sets. So we're linking across ambulance, emergency, and a bit of patient data. There are a whole range of secondary outcome studies. So we're looking at changes in suicides. That will take some time because of the time lag. We're also working with another Macquarie University organisation called MOOSH, who are doing our health economic evaluation for us. As I mentioned before, the Australian Institute for Health Innovation is doing our implementation evaluation. And then each of the 9 strategies has its own evaluation. And again, each of the strategies also has its own process and fidelity measures. So I think I mentioned earlier that we're using randomized step wedge design. And what that means is that each site starts implementation at a different starting point, and they were all randomly assigned to a different starting point. So 4 months apart. And the idea behind this is it strengthens our ability to make the link between any change we see in suicide outcomes and the program itself. So if we see that change coincides with implementation across the 4 regions, we have a stronger argument than if we just used a pre-post design. We did look at using a cluster randomised controlled trial, but we simply did not have the resources to do that. It would have required a very large number of clusters, and we're also concerned about the increasing level of suicide prevention activity across the whole of Australia and whether we would actually be able to find good control sites. And as it's turned out, we probably couldn't have. So in hindsight, it was probably the right choice to go with the step wedge. For those of you who are interested in these kinds of things, that's our study protocol, which was published in Trials and goes into a great deal of detail about data and analysis and the strategies themselves. And just to give you a sense of what we mean by a data-driven approach, so for each of the sites, we did what we call a suicide audit report, and that was a report where we geospatially mapped all suicide deaths as well as some of the attempt data to identify what were the kinds of clusters occurring in suicide, what were the primary means of suicide within a region, and who was most at risk. And indeed, this paper led by Michelle Torrick, who's my co-conspirator on this work, showed that there were significant differences between regions in terms of all those things. So the means of suicide, the demographics, the groups who are most at risk, where suicides were occurring. And so these reports were used to plan suicide prevention activity in each region. So once we'd done the report, we then went to the working groups and stepped them through all of that and allowed that to be the data that would guide their suicide prevention planning at that regional level. So what we're finding is that even state level statistics really can hide a lot of variation, and so we think this small area analysis is really quite important. So this is just a bit of a map to show you where all of these trials have taken place. So the 4 green dots are our high fidelity New South Wales trial sites. The orange dot that's kind of mixed in amongst those 4 green dots is our ACT site. You can see the national trial sites are scattered all around Australia, so some fairly remote areas, including the Kimberley up in the top end. Townsville was a site that was focused on the veteran population. So each of the national sites selected a priority population, and I think 7 of the 12 chose to focus on Aboriginal and Torres Strait Islander communities. Several of them focused on LGBTQI and others focused on different age groups. So a mix of priority populations there. In Victoria, as I said, we had a number of place-based trials. So yeah, a really large increase in this kind of suicide prevention work happening. So I wanted to take you through this implementation structure, and this comes to you courtesy of Janet. So thank you, Janet, for pulling this together. I made just a couple of additions to add in a bit more detail. So our 4 sites in order of starting were Newcastle, the Illawarra Shoalhaven region, Central Coast, and the Murrumbidgee region. So a mix of urbanised, regional and more rural sites. And the way that it was set up was that I guess Black Dog Institute held the funding, and we funded coordinator positions as well as providing funding to each of the regions for each of the strategies. And we ended up with this structure which looks something like having 1.5 roughly full-time equivalents coordinators in each of the regions, and then an alliance or a collaborative set up within each of the regions, and that could be led by a local health district, a primary health network, a non-government organisation, or a combination of all those things. And the way it ended up was that we had a couple of sites that were led by primary health network, one that was led by the local health district, and one which was led by a collaborative which sat across both of those, so the LHD and the PHN. And each of the regions ended up having a structure that looks something like having a working group that focused on health service improvement, one that focused on community, and one that focused on schools and young people. In some sites, the community and means restriction public safety were combined, and there were also different priority population working groups. So our structure at Black Dog ended up aligning fairly closely with that. We had an implementation team, a research team, and a data team, and then we had cross-cutting structures where we had health, community and schools focus. So our internal structure aligned with what was happening within the regions. And in terms of our implementation support, as I said, we funded those coordinator positions. We acted as a liaison with government agencies and departments, as well as with program providers. So, for example, if a program needed to be introduced to Australia and scaled up, we were the organisation that managed all of that on behalf of all the sites. We did use an implementation framework to support implementation of each strategy. We set up data dashboards as well, so that each site could see how they're progressing with each strategy. So there was a bit of feedback loop there to keep people engaged. As I said, we managed the introduction of new programs, and we also coordinated ongoing contact with each site and also between sites. And actually, that was a really important part of the work, was making sure that sites were supporting each other, and that was a really critical part of their success. These are some of the resources we developed for implementation. So you can see there's a lived experience framework, a number of guides, evidence summaries, readiness and fidelity resources, and so on. I won't go through that in any great detail. I wanted to just give you a bit of a sense of where we got to in terms of some of the process indicators. We don't yet have the primary outcomes. We're expecting to receive those data this month. So across all of the 4 sites, we ended up with more than 47 people with a lived experience of suicide lending their voices to the work, about 150 organisations working together to reduce suicide and build that community safety network. We introduced a program called Youth Aware of Mental Health, which is a school-based program which is aimed at Year 9 students. So it's a universal program. So all Year 9 students went through a program which was 5 sessions facilitated by trained facilitators and helpers, and comes out of Europe and was part of a large randomized control trial which showed that it does reduce suicidal behaviours, improve mental health and improve help seeking amongst young people. So all up, we got all bar 1 of the public high schools in all 4 regions to participate in that program. Nearly 13,000 students did all 5 sessions of the YAM program. And, so it was a bit of a flagship for us. We had over 5,000 community members trained in how to recognise and respond to suicide risk, and around 900 health professionals who completed some form of evidence-based suicide prevention training. So those are the kinds of measures that are relatively easy to capture. What's harder sometimes to capture is what actually changes within a community or a region when you bring together organisations with a strong focus on an evidence-based framework. And so this is where the wonderful work of Janet Long came in with her social network analysis. So this work really used that approach to try and measure the building of social capital within each of these regions. And from my perspective, I think this is one of the most interesting outcomes of the work so far. So what Janet did was to survey people to look at what were their ties within the region before they started lifespan. So, for example, who in Lifeline was working with someone in the LHD, and then to measure that again about 18 months into implementation. So what you're seeing on the left-hand side there is people's existing ties. In the middle is the new ties that they formed across that 18 months of lifespan work. And then on the left-hand side is the total number of ties that they had at the end of that 18 months of implementation work within lifespan. So you're seeing this much richer network of connections within each of the regions. So, and that was reasonably consistent across the communities who participated in this work. And so really, I think what we're looking at here is, change in capacity at that community level and changing the context in which health behaviours are grounded. So harnessing some of those positive community factors, so a sense of belonging, but also improving outcomes through enhanced programs. And we see that enhancement occurring because people are able to collaborate more effectively. There's greater shared clarity of vision. and also a real varied expertise that's brought to the table in this space. So some of the qualitative work that Yvonne and Janet were able to do was really around the value of that collaboration across organisations and across sectors. So I'm going to move away from lifespan a little bit now and bring you back to the final advice, which is the most recent piece of work, that's a substantial piece of work that's been done at that national level, I suppose, in suicide prevention. So this is the work of the National Suicide Prevention Task Force. And as I mentioned before, it's a culmination of many, many studies, many rapid reviews, and it really is an excellent piece of work. I guess what remains to be seen is the extent to which the government takes up the recommendations that are contained in the report. And so the report contains 8 overarching recommendations. Each of those has about 3 or 4 priority actions attached to it, including, and this probably won't come as any surprise to you, given what I've been rambling on about, is strengthening the resourcing for regional suicide prevention. So that's one of the recommendations they're making. Another is that establishment of real-time suicide registries, which is already unfolding. And importantly, I think this is a bit we haven't really touched on yet, is working towards a suicide prevention in all government policies approach. So for all governments to build capabilities within key policy teams and departments so that they can review existing policies to enhance opportunities for improved suicide prevention. They've also recommended the establishment of a national office to coordinate suicide prevention activity across the country and having a new national strategy that's based on this report. So it'll be interesting to see what evolves out of this. So I guess the challenge is you know, how do we make sure that we continue to have this really integrated approach to suicide prevention where we don't just see different agencies going off and doing different things, but not really connecting the dots. I wanted to kind of step back from that regional level activity a little bit now and talk about what we know about the social determinants of suicide. So there are some areas where the evidence is reasonably clear. And one of the things that we have seen in the past decade is an increase in suicide rates in areas where we have lower socioeconomic populations, but generally a decrease in suicide in more advantaged areas. There are, of course, some exceptions to that, but that has been the general trend. And as we see increasing inequality of income and socioeconomic benefit, you know, I think it's reasonably clear that that's likely to contribute to increased rates of suicide. And I mentioned before that suicide can't just be a health focus, it needs to be a non-health focus as well. So when we look at some of the non-health policy settings that can impact suicide rates, unemployment is one of them. So having strong employment policies, having equity in employment, welfare support versus austerity solutions when we see an economic downturn, alcohol availability and particularly pricing, pricing, more outlet density and availability, but also pricing has an impact on suicide rates. And again, some reasonably good evidence around that when we look at some of the national studies that have been done elsewhere, access to secure housing. Interestingly, given the marriage equality debate that was going on a couple of years ago, there is some evidence that improving rights for people in the LGBTQI community is likely to see a decrease in suicide rates amongst that community. And as I mentioned before, improving access to mental health services is also an area where we've got reasonably good evidence for an impact on suicide rates. This is a paper I was chatting to Janet about before we started this that finally got published late last year, early this year. We had tried to get it published pre-pandemic and there actually wasn't that much interest. So it was quite a slow paper to get published. But once the pandemic hit, there was, we actually found it much easier to find a home for it. So what we looked at is whether more generous social welfare benefits can actually reduce the risk of rising suicide rates when we're seeing an upturn in unemployment. And some of that evidence comes from the global financial crisis. And the answer in short is yes. So in general, when we see more generous social welfare support, we see no or lower increases in suicide rates when we see an increase in unemployment. So these are some of the non-health policy areas that we think are important to focus on. And again, pleasingly, during the pandemic, we did see the government spending a significant amount of money on supporting people through periods of unemployment. And we think that actually has contributed to actually seeing no rise in suicide rates so far through 2020, so through the pandemic again, which we're delighted to say a lot of us were wrong about. Actually, a lot of us were thinking that there would be an increase, but yeah, very pleased to be wrong so far, and hope we continue to be wrong. So at Black Dog, we turned that into a chapter in one of our white papers, and we made some recommendations for policy. And again, our recommendation was really around making sure that when governors making any kind of policy decisions, that they factor in the impact on people's mental health and suicide risk. And we were encouraging the National Suicide Prevention Task Force to consider the full policy landscape when they brought down their final advice report. So I guess the question is, how do we actually achieve that integration of the impact? So I'm going to draw on a few examples from our lifespan research trial. So one example that where we saw some synergies, I suppose, was in the area of media reporting. So some of our sites worked very closely with their media outlets to encourage a change in the way that they talked about suicide, and to make sure they included the voice of lived experience, and then to have a call to action for people to actually complete the community suicide prevention training that we had made available for free to the community. So that's linking across the media and the community strategies. And the same with the school-based program. So when we started talking to schools about rolling out an evidence-based program, they were really keen to make sure that their staff were also trained up to support students, and that they had really clear referral pathways for students who were identified as being at risk. So we started to see that integration between workforce capacity building, working directly with students, but also making sure that we're working hand in hand with our healthcare agencies to have clear referral pathways for students. And the same in the health space. So we see increasing that integration between crisis care options, aftercare options, and so on. At a regional level, making sure that we're funding and supporting those regional alliances or collaborations that cut across the different sectors and organisations. So that idea of building that community social capital. And again, making sure that when we're creating increased awareness of the need for people to seek help if they are feeling unsafe, that we're actually able to support that with a quality health service response and non-clinical options for people who are at risk of suicide. So it isn't just that focus on clinical services, but also non-clinical and peer-supported options. So this is pretty much my last slide, and it's my rather possibly preliminary attempt at trying to draw a model where we might see that coordination at the regional level, but also that coordination between the different levels of government. So I guess this is where I see some of the benefits of that kind of vertical integration. So again, one of the reasons that our school-based program was successful was that we were able to get the education department really on board and committed to providing YAM to all schools, and they worked very closely with the schools to make sure that happened. So when we see regional activity that's supported by the right level of government, we see big successes in that area. The same with the media training. So we already had a media policy, a national media policy around the safe reporting of suicide. So we were able to leverage that and to draw on the training that already existed to support regions to work with their media outlets. So where we see that alignment between regional activity, state government resources and policies, and federal government resources and policies, that's where we start to see greater successes in implementation, and hopefully also reductions in suicide and suicidal behaviour. So at that state level, they're focused, because they're largely funders of health, funding health and the education response, so crisis care, aftercare, mental health care, also first responders. As I said before, a person's experience of first disclosing their suicidal thoughts is critical in supporting them to engage in future help seeking. So our ambulance, our police, our emergency department staff are all critical as part of that first response. And as I said, the state government has already set up the data registry. At the national level, we really need that strong policy framework, which includes employment and social welfare, alcohol availability, means restriction, and data integration. So making sure we've got access to the whole national picture in terms of data. So this is kind of where I think actually suicide prevention is heading, and probably where it should be heading. With that, I will pause. I think, Janet, you're moderating our questions, so I'm happy to open up for questions.
Thank you so much, Fiona. That was amazing. Very, very comprehensive talk and very clearly explained. We've had a number of questions in the question and answer panel. So I'm just going to read out a few of those if you're happy to take questions, Fiona.
Sure.
So one person is asking, were any of the strategies specifically for those over 80 years old? Can you comment on that particular group?
Yeah, so look, our lifespan framework is a whole of population approach, and so in the national trials, some of the sites chose to focus on that older age group, and some of them chose to focus on younger people, but the framework itself doesn't specifically target a particular group, but some of the sites chose to focus on that older age group, yes. And often it's, the thing that contributes to the higher risk, I think, is often chronic illness, chronic pain, but particularly for people who perhaps lose their husband or wife or partner and are feeling quite isolated and alone. So the strategies, they really do need to be tailored to each risk group. So it's a really important question.
Great, thank you. There's another one about a section of the population. It says, how much does community and institutional racism, in addition to unconscious bias and the impact of colonialism, impact higher deaths by suicide in the Aboriginal and Torres Strait Islander communities?
Yeah, oh, look, hugely, I think. I've never seen anything that's actually been able to quantify it. But yeah, it's clear that all of those things, so the experience of daily racism, discrimination, as well as the intergenerational trauma have been, a big contributor to the very high rates of suicide we see in the Aboriginal and Torres Strait Islander community. So overall, it's about double that of the general population, and higher in some age groups. I think what is important to note, though, is the incredible resilience of those communities and their very strong leadership in working with communities to make sure that their community-owned solutions, and the importance of that as well. So Pat Dudgeon, Tom Calmer are amongst the senior leaders in that area, but there are many, many younger people who are emerging in this space who are really taking a strong approach to suicide prevention. I did mention I was going to have to apologise for my dogs at some point, so I'm sorry if you can hear the door rattling in the background. That's my dog trying to get in.
We've had a question. Would you be able to discuss a bit more about the evaluation that you applied?
Oh gosh, I could talk about the evaluation forever. Yes, so really what we're doing for our main outcome, as I said, none of the data sets are perfect for identifying all suicide attempts or episodes of self-harm. So what we're doing is a data linkage study, and we're linking across, as I said, ambulance, emergency department and admitted patient data to identify as many cases of self-harm and suicide attempt as we can without duplicating, of course, which is why we're doing the linkage. So we've got data back to 5 years before implementation and 12 to 18 months after the end of implementation. So effectively, we're doing an interrupted time series analysis to see if we can see a change in that as the outcome, and then doing a similar thing with the coronial data once we're able to get access to that. The problem with using the self-harm and suicide attempt as as an outcome, of course, is that no data set detects all of those incidents. So, you know, there are often attempts that don't turn up in any of the data sets. So it's imperfect, but so is the coronial measure. So it was a bit of you know, debate as to which outcome we should use. We are also so we've got a wonderful cohort study for people who presented through the ED to see if people's experience of the emergency department and crisis care is changing. We're doing an evaluation of the school-based program, Youth Aware of Mental Health. We've been doing an evaluation of the community training program. Yeah, as I said, I could talk forever. There's about 12 or 15 studies, not including the ones that are being done by our partners at Macquarie University. So yes, it's a big program of research. My contact details are on there. So if you want more information, I'm really happy for you to follow up with an email. I can send you the whole framework.
Wonderful, thank you. Look, we've only got like 30 seconds left. So probably won't launch into any more questions. Yeah, I think that's reasonable. Okay, so look, thank you so much for the presentation today. So the recording will be made available on our YouTube site, and everyone that's registered for this this presentation today will receive a link to it. So there were some people asking for the slides. You'll be able to review them on that link. And you will also, as I mentioned before, you'll receive an invitation to our next webinar, which will be on aged care with Professor Kathy Eager, Director of the Australian Health Services Research Institute at University of Wollongong. So thank you everyone for taking part today and for your questions, and particularly for Fiona for her fabulous presentation. So thank you and good afternoon.
Thanks everyone.